All right, good morning, everyone. Welcome to another AMSSM Sports Ultrasound case series. Today we have Dr. Kathy Vidlock Granley presenting on Extensor Pollicus Longus Rupture. Dr. Granley is an associate professor at Rocky Vista University College of Medicine in Parker, Colorado. She leads their ultrasound and MSK2 curriculum. She completed her family medicine residency at the University of Minnesota North Memorial and a sports medicine fellowship at the University of Iowa. She's involved in AMSSM ultrasound and education committees. And due to a last minute conflict, she's unable to present in person, but we do have a video of her talk and we'll play that and then have some discussion afterwards. So I'll get that started here.
Good morning, everybody. Thank you so much for asking me to do this talk. I'm honored to be here. I just want to thank those in charge of putting together these presentations. I know it's a lot of work organizing all of this, and I want to thank you for your time. I really enjoy looking back through these when I have questions about a particular case, and I can learn so much from them, so I really appreciate it. Today, I'm going to walk through a case involving an extensor pollicus longus rupture. I have nothing to disclose. The objectives for today are to walk through a case presentation, discuss the protocol for the dorsal wrist to meet criteria for a complete scan, to review the ultrasound images for this protocol, discuss the pertinent anatomy and pathology for this particular case, and to review the ultrasound report, and then a quick summary. So on to our case. This was a 17-year-old male soccer player. He came in with an inability to extend his left thumb after feeling a pop while shampooing his hair that morning. He had been seen 7 weeks prior for a Fuchs injury while playing soccer. At that time, he had a non-displaced distal radial fracture with intra-articular extension involving the dorsal medial radius. No step-off, no displacement, no shortening. He had been placed in a cast, repeat imaging at 5 weeks, unremarkable. At that time, he had full range of motion and strength and returned gradually to daily activities. He reported no problems until the day of this visit. His exam showed no edema, ecchymosis, erythema, no deformity, no tenderness to palpation. He was unable to initiate or maintain extension of the thumb at the MCP or IP, but had full passive range of motion, no laxity of the thumb. Radiographs showed a healing fracture with no new displacement or osseous abnormalities. It's always a good idea to look at every imaging study you have. The office that I was at when I did this case, unfortunately, had an issue with their system and lost radiographs for a small time period, and this was one of them. So this is not this patient's x-ray, but this is similar to how it looked. When doing a diagnostic ultrasound, it's great to have a differential in mind and make it somewhat broad so that you're not going in only suspecting one thing, just in case there is more than one thing wrong or there's something entirely different than what you suspect. So here's a quick differential of what we were thinking when we went to do this diagnostic ultrasound. Let's walk through the protocol of ultrasounding the dorsal wrist. I like to think of this as two different areas, required and optional, kind of dependent upon the clinical question. And with the required, I break it up into extra compartmental and the compartments. When I'm looking at the extra compartmental structures, I start with the distal radial ulnar joint and the recesses, the radiocarpal, midcarpal joints and recesses, and the scapholunate ligament. Then I move to the compartments. For sure, looking at them in short axis, potentially also in long axis, depending upon the clinical picture. Checking the extensor retinaculum, the tendons, the pertinent neovascular structures, such as the superficial branch of the radial nerve in the first compartment and posterior interosseous nerve in the fourth. After that, think about what optional structures do I need to look at for this exam. Oftentimes we may need to look at the TFCC at intersection sites where the first and second compartments intersect or the second and third compartments intersect. We may need to look at certain osseous structures, either for fracture, degeneration, or other osseous abnormalities. Nerve entrapments, especially superficial branch of the radial nerve or posterior interosseous nerve, dorsal ulnar cutaneous nerve, and others that are in the area. Sometimes we'll want to do a dynamic extensor retinaculum exam and potentially look at ganglions, other masses, cysts, things that are present as well. I do find that when I first started doing ultrasound, it seemed like dorsal wrist would be really easy because it's superficial, structures are not terribly hard to find, and it's all kind of neatly laid out in compartments. But I think the more that I learn, I realize there's so much more details than what is first anticipated, and a lot of anatomic variability as well. And we keep getting better ultrasound machines, and we're able to see these things in more detail, so it's more complicated than I first thought. As far as technique, we should be using a linear transducer. You can use a high frequency linear or even a hockey stick transducer. I kind of prefer the hockey stick unless the patient is pretty large, but some of that is just personal preference, and it can also depend on the patient habitus. We usually have the patient sitting with the hand on the table. I also like to have them sometimes have their elbow flexed with the hand in the air, so elbow would be flexed to like 90 degrees. Especially when looking at the sixth compartment, because sometimes you really need to have them hyperpronate if their hand is flat to get to that, and it might be easier for the patient to sit with their hand up in the air instead. Again, that's partially personal preference. It's going to be an MSK setting, and remember to use a lot of gel because, especially on really skinny people or bony people, stacking the gel can really be helpful to see the structures. So having landmarks in any ultrasound exam is a great idea. And for the dorsal wrist, Lister's tubercle is a really easy landmark to find. Classically, it's between the second and third compartments, but the more ultrasounds that I do, the more I realize that the morphology here can be greatly varied. Sometimes you will find EPL on the radial side of Lister's. You will also notice that Lister's tubercle can be really peaked or more flat in different people. You can see bifid Lister's tubercles. The position of EPL at times places it really superficially, almost right superficial to Lister's tubercle, and that can correlate with more common injuries of the EPL, so just be aware of that. So starting the scan with the DRUJ, and you can see on the left here is an unlabeled image, and then the right is labeled. And the area at the bottom is just showing the position of the transducer. The left side of the image in these is going to be radial sided. So we're just scanning throughout the DRUJ. You're over the fourth compartment as well. You can also see the extensor retinaculum in these images. I don't find that this is a great image for degeneration. Sometimes you will see it, but I do get better idea of degeneration of the DRUJ from radiographs often than I do from this image. Remember to scan fully along the joint to get the full picture here. The next view that I do is looking at the proximal and distal radiocarpal joints and recesses. And you want to scan along the full width of this as well. Make sure that your view shows the radius, lunate, capitate, and that third metacarpal. The proximal recess is going to be right over the lunate, and then the distal recess kind of hugs the capitate, and it's generally flatter, as you can see on the bottom image here. So make sure that your patient is not in wrist flexion or a palmar flexion type of position, because at times that can give you a false positive and make the joint space look a little bit bigger than it really is. You can always add Doppler to look for synovitis as well. The next thing I look at is the scapholunate ligament. And again, I go back to Lister's tubercle. We're going to be in the transverse position. From there, I'm going to just slowly move distally until I see the scaphoid and the lunate bones, and then looking for the fibrous structure that's in between those, and that is your scapholunate ligament. There are three portions to it: the dolar, the volar, and the proximal portions. We often will do stress views to see if we see widening of that space. You can do a clenched fist view and look at the space. I actually find it more useful to have the patient radially and ulnar deviate. It seems like I get a better picture of the widening with that than I do the clenched fist view. I actually think this is a place where ultrasound really shines over MRI, because in MRI we need to have the still pictures, and so watching the dynamic movement of the osseous structures with the radial ulnar deviation can really be a better picture of the scapholunate ligament itself. Let's move on to looking at the compartments. So again, I start at Lister's tubercle, and then I move radially over to the first compartment. Be really careful when you go from the second to the first, because we do have that superficial branch of the radial nerve. And if you put too much pressure on that as you're curving over the bone, it can give the patient a little bit of a zinger. So in the first compartment, we have abductor pollicus longus and extensor pollicus brevis. And we also have the radial artery and the superficial branch of the radial nerve. We can look at these in short and long axis, as is shown here. These are both deep to the extensor retinaculum, which in the first compartment is usually about 0.9 to 1 millimeter. They are superficial to the radius. One of the things to note about this compartment is that you should look for an osseous ridge. And if you see that, that is a clue that there will be a septum and likely separate tendon sheaths for both of these tendons. And that can be really important to know if you are planning to do an injection, because you may have to inject into both tendon sheaths separately. The APL tends to be the larger of the two tendons. It can have a really variable appearance. It can have a multilamellar appearance, and you can see that here. This person does have that, and it can look like a little split tear. That's just the variable appearance of the APL. One other thing to notice as you go through the compartments is that you can have distal muscle bellies at this level. And while it may look hypoechoic, more like fluid, it's actually probably just muscle belly, so you may want to follow it and see what happens. It tends to lack that traditional speckled look sometimes in these views. Next thing to look at is the second compartment. We're just going to move a little bit ulnarly. Again, these images are radial on the left side, ulnar on the right side. The second compartment has extensor carpi radialis longus and brevis. And this is the compartment that does have some intersection with it, and I will come back to that in a later slide and go over that. Remember that in any compartment you can put Doppler on to look for hyperemia, neovascularization. Next, we move to the third compartment, which is the one we've been excited to see for this case. These are some normal views of a third compartment here. And you can see this is kind of a little bit different morphology of Lister's tubercle here as well. And again, remember that EPL for some people is more on the radial side than the ulnar side, but not in this example here. And this is just normal long and short axis look at that EPL in the third compartment. This is not our patient who had the issue. So here's our case with this third compartment view. And you'll notice in the first image on the upper left, there appears to be this absence of the EPL. And remember that we can always have anisotropy, so we have to toggle the transducer, make sure that we are really seeing fluid there instead of the tendon, and that was the case here. You can see this then long axis as well on the views on the right. So the bottom right-hand view shows that we have the proximal end of that EPL shows a little stump kind of right in between that scaphoid and trapezium. And then the green arrow shows the beginning of where the tendon is visible again, just right at that distal edge of the scaphoid. So in between that, there's that hypoechoic fluid. Even though we have a good idea of what's going on with this patient, we want to complete our protocol for a complete diagnostic ultrasound. So we'll move on to the fourth compartment. And you can see here the fourth compartment has extensor digitorum, extensor indices, and the posterior interosseous nerve. That nerve is deep to the tendons. And you can see that in long and short axis in this view. The other thing that I like to look at in the fourth compartment is to take a good look at the extensor retinaculum. The retinaculum can have some impingement here. It can get thickened. In athletes who have a repetitive wrist load, you will sometimes see that. The next compartment we look at is the fifth compartment. We have extensor digiti minimi in this compartment, as seen here in short and long axis. One thing to note about this compartment is that if you have DRUJ arthrosis, occasionally that can cause a rupture of EDM, so just be aware. Next, we have the sixth compartment, and this is where we either need to have the patient really hyperpronating or potentially sitting with their elbow flexed and their hand up in the air to get a better look at this. We have the extensor carpi ulnaris in this compartment. Remember that with the retinaculum, there is this superficial retinaculum that comes over the ulnar ridge and attaches to the pisiform bone, and then there's a deep fibrous subsheath that tethers along the ulnar groove and gives stability as well. One thing to know with dynamic exam of the ECU is that we often will see the ECU come at least halfway out of its little groove, especially with a lot of supination, flexion, ulnar deviation. So just be aware that that is a normal variant. I just wanted to walk through a few of the optional views and know that there are many more that you can take, but these are just some of the more common or interesting ones. And certainly one of those is this intersection between the first and second compartment. This intersection occurs more proximally than the intersection of the second and third. The first compartment is more superficial to the second compartment, as is shown in the pictures here. And when I am looking for intersection syndrome, I do put Doppler on to look for hyperemia, but I have certainly seen patients with crepitus and other symptoms who don't show a lot of hyperemia. Here's a view of the intersection at the second and third compartment, and the third compartment overlies the second compartment in this intersection, as is seen in the picture here. Here's an optional view of the TFCC, and this is a structure that we could definitely spend a really long time discussing, and I won't do that today, but realize that there's many components to this and that it goes much deeper than we initially may think, all the way down to the radius. You can see the little picture of the different portions of it. One thing to remember to watch for is that depending upon your angle, sometimes you can get posterior acoustic shadowing from the ulnar that can make structures seem like they are not there and more hypoechoic than they really are. Although that articular disc, as it gets deep, does appear more hypoechoic naturally. Let's move on to the report for this. In any report, you want your title, you want your indication, which I usually put as pre and post procedure diagnoses. You want to correlate it with other medical imaging that has been done. List your findings in detail. And then you want to list your impression. That may include a differential, or it may include something very specific that you have found on the exam. Here's the report for our patient. So we have complete diagnostic ultrasound of the left dorsal wrist. The referring physician, in this case, there was none. Our pre-procedure diagnosis is decreased range of motion of the left thumb, and our post-procedure diagnosis is Extensor Pollicus Longus Rupture. Our comparison is the radiographs that we had, and we just state that we did a complete ultrasound along with the structures that we looked at. Then we go to our findings, and we're just going to be a little bit more detailed about looking at the dorsal joint and recesses, and then the scaphoid lunate ligament, and then we look at the extensor compartments and talk about the details of the findings. In the end, the impression here is going to show that this was an abnormal, complete diagnostic ultrasound of the left dorsal wrist with a complete tear of the EPL, with retraction, with the proximal portion ending at the trapezium and scaphoid, and then the distal portion of the tendon seen again at the distal scaphoid. The outcome for this case is that the patient was referred to hand surgery. He underwent an EPL repair and he did really well. In summary, remember our technique is the linear probe. Remember the positioning is with the hand prone or with 90-degree flex elbow with the hand up in the air. You start with Lister's tubercle and you can keep coming back to that for your main landmark. Remember all of the different morphologies of it. Go through the DRUJ, the recesses, the scaphoid lunate ligament, and compartments 1 through 6, and then add on any optional testing that seems to be pertinent to your case. When you're looking at tendons, remember the anisotropy. Find the ends of ruptured tendons, if you can, like we did in this case. And finally, as is true in ultrasound in general, adhere to your protocols, because you may miss something else. Maybe there would have been another tendon that was ruptured or something else going on in this case. So stick to the protocols in the end. Again, thank you for asking me to come in and do this talk. I'm sorry I cannot be here live on Zoom, but please reach out to me if there are any questions or comments, or if I made a mistake on here in something I said. Thank you.
All right. Well, gosh, that was a fantastic presentation. I know Kathy's not able to be here with us live, but that was absolutely great. That was exactly what we're looking for. Going through the protocol, and I think that the hand and wrist in particular are areas where I think the protocol of assessing this is really important. And one of the reasons for that is there's frequently several different things at the same time that are, co-occurring. And in this case, there was one diagnosis in particular, that was relatively evident, it seems clinically, but also confirmed sonographically. But that's oftentimes not the case. There's oftentimes several different things happening at the same time. And just a couple of thoughts I have, especially on these EPL ruptures and then the dorsal wrist protocol. I think one is really important to evaluate the intra-articular structures for the wrist, and that's something that I think is important everywhere, but in particular the hand and wrist and the foot and ankle. I think it's a little bit more challenging on physical examination sometimes to determine the cause of pain, and when there's something like a tendon rupture, that's a little bit of a different story, but I think it's important to still go through that kind of protocol. With the EPL ruptures, I've seen several of these, and they tend to occur with a relatively innocuous sort of injury. So, like, doing something to their hair, like this patient, or just putting their, hand in their pocket or something. But they oftentimes follow something else, and distal radius fractures are notorious for this. And you can see these both with distal radius fractures that are treated surgically and non-surgically. And so these non-displaced ones, surgically, oftentimes I've seen several people who have had like a protruding screw dorsally, and the tendon is just abrading on kind of the threads of that screw and causing attritional tearing. But even in the non-surgical ones, you oftentimes see a lot of cortical irregularities. And one thing I noticed on some of the images, there was a cortical irregularity right over Lister's tubercle that I saw. And I think those probably contribute to this. And we talked about this a couple of weeks ago with the FCR injuries, and that there's kind of this abrasive sort of phenomenon when a tendon turns a corner around something that is irregular. And so I think that contributes a lot with these EPL injuries. And so just paying, real close attention to that. The other thing I'll say is, a lot of times these are not repaired in a kind of end-to-end fashion because they retract so far, and there was a reason that they tore in the first place. And so frequently there's a tendon transfer, so the surgeons will transfer the EIP tendon to the EPL. And so whenever I see a EPL tear, I'll oftentimes take a look and just make sure that, the EIP tendon is intact and normal looking. And I'll just make a comment in the report that it, is an appropriate tendon for transfer if applicable. And then, as you mentioned, as was mentioned, looking at looking for anisotropy, if that's, possibly the reason you're not seeing a tendon. And there's some other reasons this can happen too, is the tendon can dislocate. So it can, be actually sitting on the opposite side of Lister's tubercle. So it can sit radial. And so you could, miss it in that way. Or, the fourth dorsal compartment tendons could be sitting kind of next to Lister's tubercle, and you could mistakenly think that the tendon is intact when it's really torn. And some people have variable kind of Lister's tubercle morphology. So it can be just a sharp peak. It can be a relatively, shallow hump, or it can be kind of almost like a camelback, like a two humps and with the tendon sitting on top there. And so there's several different morphologies that this can take. And so, being really diligent about tracing the tendons all the way to their distal insertion to make sure that you're not missing something or inappropriately calling a tendon injury that is just maybe located somewhere different. Those are kind of the main points I had. I'll open it up if anyone else has any comments or thoughts on this, but that was a great case.
Yeah, Brennan, I definitely would reiterate. I actually had one of these cases this week, so this was just a really good kind of review to go into it. So yeah, a couple of points that I just wanted to kind of reiterate that you guys had already mentioned a little bit. I mean, first and foremost, like you had mentioned, is I think definitely doing just a comprehensive exam, still in these cases, even though they seem very clinically straightforward, just because that can be really helpful, as you had mentioned, for our surgical colleagues, especially if they're going to be doing any type of tendon graft, for that procedure. At least evaluating, as you had mentioned, in its entirety, the EDC and the EI tendons as well too, just because, as you had mentioned, sometimes they'll use those for the graft and repairs. I thought Kathy made a really good point about the anatomical variance for the Lister's tubercle. And then also just in addition, mentioning that along with this, then you can get those kind of subluxations of the EPL. And that's where these injuries, sometimes can be, a little bit more difficult to diagnose than you kind of first imagine. It's just, one of these that you're going to that home base, as she had mentioned for this Lister's tubercle, and you just expect to see EPL there. And then when it's not, you're just trying to figure out, is this, sublux? Is there some type of anatomical variant, or is this, truly a tendon tear? Almost kind of equate it when you go up to the shoulder and the biceps tendon sitting in that bicipital groove. And the first time that you go to the home base and you're not seeing it at that location, really kind of need to think about exactly what's going on at that location. So a couple other, thoughts on these cases. As you had mentioned, I think kind of the most common, pathology is going to be, something potentially traumatic like this with a Fuchs type, mechanism where, the Lister's tubercle may cause some type of impact along that tendon. But also, as you had mentioned, going to be seeing this very frequently with, hardware, which obviously can cause direct complications as well too. But even if there isn't, a direct hardware complication with like a screw or a plate on that side. Sometimes even with the way that these fractures will heal along the radius, sometimes they can get some scar tissue formation at that area too, which can cause, some attritional tears as well too, for the EPLs that I've seen. Kind of two other thoughts. Sometimes with these cases, I think it can be, as we mentioned, they can be a little bit subtle. And so I think it is very important to do some dynamic scanning in these cases as well too, especially as you're kind of looking at the differences between the third and fourth compartment. If you can try to have the patients, it can be pretty apparent that you're not seeing that pull through any longer of that EPL. And then lastly, she had mentioned kind of putting down exactly the locations that she saw the tendon where it was torn. I think another option for this, especially once again, just for the surgical colleagues, is just kind of measuring, the exact location, where the EPL tendon has started, and then kind of where the distal tendon stump is located as well too. So those are just some thoughts from this case, but I thought an extremely excellent overview of this type of pathology.
Hey, this is Ryan. I'll just add just quickly, I agree with all the points that both of you guys made. And like you said, Kathy, really hit a home run with this and did exactly what we were looking for, what we've always been looking for, which is excellent. And so we really appreciate her putting this video together, despite some other things that have come up that precluded her from being here today. I don't really have any more specific comments. I mean, we could have a talk on every single dorsal compartment tendon and go through specifics, but I would just say, the dorsal wrist in this case in particular, I think really highlights the whole goal of this presentation series, which is to have a protocol and stick to that protocol. The dorsal wrist is busy. There's 9 tendons, 2 nerves, multiple joints that you can get lost in, and really just having a set protocol and following that protocol every single time, prevents you from getting into potentially dangerous fishing expeditions. So I think the dorsal wrist region, in addition to other regions, really highlights the importance of a specific protocol, and also understanding a lot of the anatomic variability in these structures, because there is quite a bit in this region. But yeah, otherwise I agree with all the comments you guys made, and again, Kathy did an outstanding job.
All right, fantastic. Thanks, guys. Well, I think that'll end it for us today. We will be back again in a few weeks on September 29th. Dr. Stephen Schaff is going to be presenting on carpal instability. So see you guys soon. Have a great weekend.